remarks, please, and could I ask that you confine them to 5 minutes, please, to allow time for questions and answers. Thank you.
Is this the Irish Cancer Society? I think I'm giving the opening remarks for the Irish Cancer Society.
Well, you are. My apologies. Well, then, could I ask? Sorry, there seems to be a typo. My apologies. Ms. Morrow, could I ask that you give your some opening remarks, please, limited to 5 minutes, and thank you.
Thank you, Chair, and members of the Special Committee on Covid-19 for inviting the Irish Cancer Society here today. We want to start by formally recording our appreciation for healthcare workers, support staff and anyone involved in the delivery of healthcare during the pandemic, which includes our own staff at the Irish Cancer Society. Their selflessness allowed for the ongoing provision of urgent cancer services in even the exponential phase of the Covid-19 pandemic. This included the Irish Cancer Society's night nursing team, who provided nursing care in the homes of patients who were at the end of their lives. Our national support line was extended to 7 days a week to assist with increased queries from anxious patients and family members. Our volunteer drivers continue to provide transport to people right across the country, enabling patients to get to life-saving chemotherapy treatment. With regard to the impact of COVID on cancer services, a few key points need to be addressed. On the 27th of March, all non-essential surgery, screening and diagnostic procedures were postponed, causing huge additional anxiety for patients. The impact of these postponements on cancer outcomes will take years to fully be uncovered, but the immediate impact is that it has led to thousands of people not being screened, as well as growing waiting lists for cancer tests and treatment. There is little clarity in sight as to how these will be addressed. It is evident that without immediate action, there will be excess and avoidable cancer deaths in the years to come as a result of people getting the care they need later than they should. An illustration of this is that we would expect about 450 cancers and 1,600 pre-cancers to have been diagnosed or to be detected in a typical 4-month period if the screening services had been operating as normal. So we are very pleased that cervical check has now resumed, but are disappointed that bowel screen and breast check may not return until autumn. In addition to screening, we are concerned that there are still symptomatic patients who have not sought medical advice and as a result may experience a delayed diagnosis and access to treatment. If action is taken immediately, the most dire predictions may be avoided from becoming a reality. Some of these are included in the submission we made to this committee. As a first step, the HSE must publish a recovery roadmap without delay, and the government needs to fully fund this before Budget 2021. The crisis in cancer care pre-existed COVID, and the pandemic has just made things worse. Before COVID, targets in the National Cancer Strategy relating to timely access to diagnostics, surgery, radiotherapy and the uptake of screening were all being missed. This is a direct consequence of consistent underfunding of a system that has been running to stand still in recent years and which has frequently budgeted in the knowledge that it will not meet demand. As such, a return to normal is in fact undesirable for us. We want to do so much better, and we need to do so much better. All of us, government, Oireachtas members, advocacy organisations, healthcare workers, need to ensure that cancer services are fully restored in the short term. We need to take the opportunity to build back a better cancer system focused on the full delivery of the National Cancer Strategy. And rather than using a challenging environment as a reason not to improve services, we need to use it as the precise reason for building back better, more equitable, high-quality care that addresses the many needs of cancer patients in Ireland.
Thank you. Had you concluded, Ms. Morrow?
Yes, I have. Thank you.
Thank you. Thank you very much. Thank you. And could I ask Ms. Klein for opening remarks, please, again, asking that you limit them to 5 minutes, please, to allow for questions and answers.
Good afternoon, and thank you for the opportunity. The IMO is the trade union and representative body for all doctors in Ireland who are delivering care to patients across the health services: consultants, public health doctors, community health doctors, GPs and NCHDs. The fundamental problem within our health services is one of capacity, and this predates COVID. As a country, we have restricted patient care to match the deficits of our services, rather than investing in those services to meet patient need. The Health Service Capacity Report was published in 2018, but little or no progress has been made since. COVID has resulted in extreme pressures on our health services. Our response should not be to limit all other care, but to proactively increase capacity to allow for non-COVID care pathways and create capacity for any COVID surge. To do otherwise will only compound the problem. It is inevitable that patients whose care has been delayed will present with more complex needs as they deteriorate, and they will suffer negative health outcomes. Mortality rates will increase. We now have a situation where capacity will be reduced by up to 50%, while at the same time there are over 800,000 people waiting for an outpatient appointment or inpatient care. We have mounting pressures on our emergency departments throughout the country. Extremely limited referral pathways are available for GPs, and there are increased pressure on GP services in situations when patients cannot access secondary care, diagnostics, mental health services and other community supports. Every year, for far too many years now, we have severe overcrowding in our emergency departments, with patients languishing on trolleys, elective procedures routinely cancelled, lengthening waiting lists and hospitals operating at dangerous levels of occupancy. Unfortunately, this year will be worse with the additional impact of COVID. In summary, we have too few beds, and we need to plan for an additional 5,000 public acute beds and 300 additional ICU beds. In this context, we must immediately embark on a temporary build programme in tandem with longer-term builds. We have over 500 vacant consultant posts, and for many years the system has not been capable of attracting sufficient numbers of consultants due to inequitable pay policies. General practice and the much-needed shift of care to the community must be planned and resourced. There is little additional capacity in general practice at the moment. We must strengthen our public health capacity. We have relied on public health throughout this crisis, but public health is understaffed and undervalued within our system. Care of the vulnerable and elderly in our society requires urgent attention, with significantly more resources deployed to allow people to remain at home. We need to continue to invest in prevention with appropriate resourcing of our vaccination programmes and significant investment in diagnostics and treatment pathways to support our screening programmes, and those screening programmes should open as soon as practically possible. We also need to invest in e-health across all hospitals and community healthcare settings. Since the commencement of the pandemic, doctors and all other healthcare workers have shown dedication to patients, professionalism and agility in adopting to new ways of working. We now appeal to you, members of this committee and the new government, to respond in kind and support us and our patients by investing immediately. This is a health crisis, and we must respond accordingly and prioritise investment in our health services. Thank you.
Thank you very much, Ms Klein. I would now like to call upon the first of our deputies to speak, Deputy Cullinan, for 10 minutes.
Thank you. Could I first of all welcome Ms Murrah and Ms Klein and thank them for their kind words that they expressed in relation to our frontline staff across all of our healthcare settings. Can I start first of all, Ms Morrow, with yourself? We're looking at, and we have to look at as a committee, and I suppose as Oireachtas members, we're looking at a health catch-up programme that includes acute care across a range of specialties. We're looking at mental health services. We're looking at older people. So obviously there's huge challenges now for the healthcare system to catch up on delayed care. But I want to first of all start, if I can, with cancer screening. And you mentioned that yourself in your opening statement. You said that thousands had not been screened. It may take years before we actually know the full extent of what that will mean for patients, that some patients may die prematurely if we don't put in place the catch-up programme, if they don't get a diagnosis as quickly as they should. So can I just first of all ask you, how serious is this matter? And are you satisfied that enough has been done by the Department of Health and the HSE at this point in time to get the screening services back up and running? Just as a starting question, please.
Deputy Cullinan. The Irish Cancer Society believes that the issue of screening is it's imperative that we get screening services restored and restored to the way that they were before coronavirus. We know that the environment is extremely challenging, but when you look at those figures that we've calculated in the Irish Cancer Society, that there's 450 cancers that have possibly been undetected to date, and the additional pre-cancers that have been undetected, I think you can start to understand that without our screening programmes, we're missing a central plank in our cancer prevention and early detection strategies. And if we don't restore them to the high-quality screening systems that were in place before COVID, then we risk actually, the general public's health and the chances that they have of being diagnosed with cancer early. And we know the importance of diagnosing cancer early as well, that if you're diagnosed at an early stage, then your chances of survival are so much better. And Ireland isn't doing well in terms of cancer survival. We're lower than the OECD average, and we need to do much better. And that's why the National Cancer Strategy sets out that blueprint for excellent cancer care, and why we as an organisation and many other organisations are extremely disappointed at the lack of momentum and funding behind that strategy. So in terms of screening, we want the screening programmes to be restored as soon as possible. We're pleased that cervical check is getting underway, but for breast and bowel screening, there are people who currently have cancer, unfortunately, and don't know it. So until those screening programmes are restored, we aren't giving them the best chance of detecting that cancer as early as it could have been.
Thank you, Ms Murray. And you said earlier that pre-COVID, it was the case that we already had untimely access to diagnostics, and now we have this backlog, which obviously creates more problems and challenges for us. The HSE, and they will tell us today that they accept that there's a developing backlog of cases, including in the 4 main screening programmes, which would include cancer. And they say that this backlog will now have to be cleared in a COVID environment. So from your perspective, if you were talking to the HSE, what's the time frame here? Because you can say that we'll clear the backlog, but in reality, how quickly do we need to clear that backlog? What kind of time frame, from your perspective, are we looking at?
We need to clear it quicker than we are. That's really the answer to that question. We need to do a capacity review, and that's one of our recommendations in the submission we've made to the committee. It's important that we know what capacity is there. If we illustrate in the case of endoscopy services, we know that their capacity has been reduced to about somewhere between 30 and 50% of pre-COVID levels. And before COVID, there were extremely long waiting times for non-urgent colonoscopies, but there is a cancer detection rate within that group. There's currently 19,000 people waiting for a colonoscopy. So how are the endoscopy services able to do more because there's a backlog with less because of the capacity issue? And we also need to remember as well, and I don't know the answer to this, whether the workforce has been returned, has it been fully restored, or are people still in roles that to provide COVID services? So we've got lots of different things to consider, but we need people to take action today because we're at a crossroads, and if we do nothing, we are facing a dire situation.
That dire situation then, if we don't take urgent action, is that unfortunately people will die of cancer prematurely because of a lack of a diagnosis. Is that the case?
Unfortunately, that is the case. We need people to be diagnosed early, and like I said, that gives them the best chance of survival. We're worried that some people haven't accessed medical services yet, so perhaps they're worried about seeking help in a healthcare environment, but we strongly encourage them to phone their GP if they're worried about going in themselves, and seek the help that they need, because again, if you get diagnosed with cancer early, you're much more likely to survive it. The likelihood is that anybody who does have a sign or symptom of cancer, that hopefully it's not the case that it is that disease, but you need to get it checked out.
I see, Ms Morrow, as well, that in your submission and in your opening statement you make reference to public awareness campaigns. So obviously encouraging people to get screened, to get checked, to have a diagnosis. But I suppose if the capacity isn't there, if the screening services aren't up and running and people are contacting the programmes and are not hearing back, that will add to their stress. So I suppose you're right in saying that we do need to have advertising programmes. You're right to say that people need to be informed, people need to be encouraged. But if we do that, would you agree it's very important that the actual programmes are up and running, because otherwise you give people false hope and actually add to the stress that people will be under? And I can just put a question to the IMO. It's a related question as well. So, Ms. Klein, in your submission, and they were both very, very good submissions, I have to say, real high quality submissions we've got from both organisations, and a lot of good recommendations I think this committee should forward on to the HSE as well. But the IMO talks about investment in diagnostics and treatment pathways are needed to support the full re-establishment of these life-saving programmes. You're talking about the screening services. So if Ms Klein from the IMO can maybe speak generally on the need to accelerate reopening screening services, from your perspective, the importance of it as well, please.
Well, yes, the screening services are very important, and they've been a major health initiative over the last number of years, so the IMO would fully support that. I think there's a slight difference in the screening services and the women and patients who are called for screening, and the encouragement of those patients who are developing symptoms outside of screening. So screening is not the diagnostic tool in and of itself. So I think that we should, the message out to the public should be, if you discover any lumps or bumps, if you are concerned, you should contact your GP. And we need very quick referral pathways from general practice into the cancer services in the hospital. So there's two elements. There is the screening programmes, which are very, very valuable, but there's the issue of the public almost being afraid to attend or concerned that that service won't be available. It's really, really important that for any change in your health, the public attend to their GP and call their GP. We cannot make everything about COVID.
Yeah, I think that's a very important point, and I accept that. I want to put to you as well just two questions, because we're tight on time, and there's an awful lot I would like to ask, but unfortunately we are confined because of the time. You mentioned the preparation for the winter flu season, and obviously because of the COVID virus, you know, there will be added concern in relation to what happens now if there's the winter flu. How do we vaccinate, how that should roll out? So you make reference to that, you might expand on it. And you also talk about the need to increase physical capacity in the system. So what we're hearing from the HSE as well is that because of the 2 metre social distancing rule, capacity is down about 25% in acute settings. So is there a need then to get additional space, physical space? Is that what you're calling for? And have you made submissions to the department and the HSE? And what type of physical accommodation are you talking about? Like what specifically, what would that additional physical capacity be needed for, from your perspective?
There's absolutely a need for additional capacity, and there has been for more than 10 years a need for additional capacity. What we can't do now is we cannot possibly accept that we are delivering a health service with this reduced capacity. That will just mean things will get worse, the problems will get worse, and people will get a lot sicker. Temporary builds have to be the first option. Purchasing or renting space will have to be the second option while we develop these longer term builds or acquisitions. So there is no reason, except for funding, there is no reason why temporary builds cannot proceed. And I might just ask my colleague, Dr. Gilligan, to talk to the bed situation.
So, as the committee are aware, we've had significant issues with capacity and occupancy in the acute hospital system for many years in Ireland. Currently, as you know, there's 580,000 people on outpatient waiting lists, and nearly 250,000 people awaiting various procedures or day case admissions. So there's huge pressures on the system. There are massive unmet needs within the system already, and that was in a system where we were running our acute hospitals at between 97 and 104% occupancy. And the public are aware of this because they're waiting on procedures, but also because of the level of crowding of emergency departments. We can never return to a situation where when a patient arrives with an emergency condition to an emergency department, they are faced with a crowded waiting room, a crowded treatment area, even a crowded resuscitation room. The only way that we can move away from that is by having the capacity. And historically, in 2018, we were advised that a minimum requirement of 2,690 beds was already present and that it needed to be addressed. In the context of COVID, that has now gone to 5,000 conservatively.
I do thank you very much, though. You may be able, somebody may wish to bring you back in on that point, but I'm going to have to give the floor to the next speaker, who's Deputy Colin Burke from Fine Gael, who has taken 10 minutes. Is that correct, Deputy?
That's right, yes.
Go ahead.
Yeah. Could I just thank everyone here for their presentation here this morning and for all the work that has been done over the last, I suppose, 4 very difficult months, and especially the frontline staff in all our hospitals and in our community settings. I suppose my first question basically is, you know, we have new challenges, as in that the hospitals don't have the same capacity because of the whole social distancing issue and all of the new processes and procedures that have to be followed. And the one area that's coming back to me on an ongoing basis is GPs complaining about lack of access to diagnostic services. I'm just wondering, is there any way that we can actually fast-track and improve on that service immediately, whereby rather than people being referred into outpatient clinics, that a lot of the work that GPs are already doing, but they have to refer in because of can't get access to diagnostic systems. How could you fast-track that improvement? And my second question is in relation to the HSE. Since December 2014, since December 2014, there are now an additional 20,000 people working in the HSE. It's gone from 103,000 up to 123,000 whole-time equivalents. If we were to prioritise recruitment in the morning, where would people prioritise? Because if you recruit consultants, it's about consultants also. It's not only about having them, but also about they having access to beds, having access to operating time, having access to support staff. So I'm just wondering, where would the priorities should be now at this stage in relation to staff recruitment?
Answer some of your questions and then pass on to my colleagues. This has been the fundamental problem, this idea of prioritising. We have to accept our health services do not have enough doctors, nurses and other health professionals working in them. We have to accept we don't have enough beds. So this idea of robbing Peter to pay Paul, make a choice between a consultant or a nurse, that's not going to improve the lot for patients. And until there is significant financing of our health services, and we have to take this opportunity, as our colleagues in the Irish Cancer Society say, we don't want to go back to the way it was before COVID. The way it was before COVID was not good. We want to move on and go back to a system that meets patients' needs, that allows people to work in a system and deliver the care which they are trained to deliver, and not be running around everywhere trying to source a diagnostic for patients. In terms of the diagnostics, in terms of general practice, I have been looking at budgets from various governments for many years that show an allocation of diagnostics for general practice, and it has yet to materialise. I do understand that this afternoon the HSE will come into this committee and say they are bringing diagnostics to general practice, and we would very much welcome that. And we would very much welcome sitting down with them and seeing how that is going to be run. Because it is true to say that if the GPs had faster, quicker access, we would stop some people being referred to hospital, but not all people. People will still need to use hospital services. So the hospital services cannot be limited by virtue of capacity. We have to think outside the box and say, OK, if this is what the limit is, how do we improve capacity, not just operate within the capacity? And I might ask my colleague, Dr Macaulay, who's the chair of the GP committee and a GP in County Donegal, to talk about the diagnostic flow through from GP to the secondary care.
Thank you, Deputy Burke, for the question. I think the principle of care within the actual community without referral to the hospital is the most the clinical evidence is that it's effective and it is cost effective as well. When that care is properly resourced and planned, it does work. Last year, the IMO introduced a deal where chronic disease management will be looked after more in the actual community, and there will be 80% of the chronic diseases will be able to be managed in general practice to a very good standard. So the actual resources is there, the evidence is there, and the planning is there. So that's actually a template that we can use for other things. But as Susan said, also 20% of those people will need to be referred on. So the concept of care in the actual community is good for a certain cohort. Now, within the actual diagnostics, there is no doubt that if it was more freely available to us, then we would be able to, as it were, tick out a certain amount of people who we'll be able to reassure them that things are fine. But it will also identify people who have to go to the hospital. There is ad hoc sort of systems throughout the country where scanning has been made available to GPs, and the feedback is that it is responsive and it's very effective, and it does give reassurance to patients early that everything is fine. It gives reassurance to the doctor that this person doesn't need to be referred, and as well it will identify people that you say, well, there's 100 people who come in with abdominal pain. You will actually screen out the ones that you feel need to go to the hospital.
Right, could I just ask the question? Does there need to be a more structured approach in relation to GPs accessing diagnostics? Because that's the big complaint I have, is that...
I think so. I think just following on from that point, is when the ad hoc system is there, when those GPs have access to that, it is very useful. But an ad hoc system is not to make the whole system effective. It has to be available to all GPs nationally, and that's why if the word that we're hearing that diagnostics, there will be a system whereby GPs will have more access to diagnostic. If that is being announced by the HSE and it is implemented and it is available to all GPs, it's something that we in the IMO would actually support.
But, you know, are you satisfied that this can be fast-tracked in order to help?
As I say, that's sort of beyond my pay grade of it. I think that if it is fast-tracked, it would be a very positive development, but whether I have no influence in that, I would only encourage that it is fast-tracked, because it will end up, it's like all systems, if it's in the community and it's cost-effective, it'll be cost-effective management, so it will ultimately save money and save lives, which is what we both want. We want to save lives primarily, but if it saves money as a secondary feature, excellent.
And just going back to the cancer services in relation to now coping with the new challenges, what kind of numbers do we need in relation to being able to deal with these new challenges in relation to staffing numbers? Have we looked at what we need in that area, and where can we recruit them from? Because one of the other issues that we have in relation to healthcare is that while everyone is talking about the numbers that we have now who are in the system, no one is looking at the numbers that are going to be retiring out over the next 3 to 4 years, which is also something that needs to be looked at. And I'm not sure if we have any figures from the HSE about the numbers that are retiring out, both in relation to nurses, in relation to care assistants, but also in relation to consultants.
I just respond very quickly on the manpower, and then Rachel will talk specifically about the oncology and cancer manpower services. We absolutely know that over 600 GPs are due to retire out of the system in the next number of years, and there are no supports to help younger GPs establish. We also know that there is a large percentage of consultants who are due to retire. This is very easy information to get. The HSE have the date of birth of everybody in the system. We have failed miserably to attract people to work in the system, and that is absolutely down to the undervaluing of doctors and indeed other healthcare professional staff within the system. So it is known in the Healthcare Capacity Report from 2018, it is indicated clearly the levels that we need in terms of manpower. However, we are not starting from a base of where we have manpower. We are currently 500 consultants short of the system. That is 20% to 25% of the workforce on any given day we are short in the system. And in this system, SPRs who had qualified, finished their training in July of this year, the IMO made a request into the HSE and into government that those SPRs would be given a locum post for 6 months because they cannot travel on to do fellowships. and they have not been given that post, and they are now operating, some are operating in jobs way below their skill level and not there to deliver the much needed services to patients.
What numbers of SPRs are you talking about in that?
There were 160 SPRs who finished their training 2 weeks ago.
And of that number?
Not one was given a locum consultant post.
Of the 160?
Yes.
And is there any response back from the department on that matter?
Well, it's a response back. Like, I mean, it was a submission we put in. There is no response back. Like, I mean, anyone can see on social media at the moment. NCHDs, the hospital doctors that I'm talking about, they're currently now working over 24 hours on a shift, which is illegal and in complete breach of their contract. They're absolutely burnt out. They have been scrabbling around for jobs at the changeover, moving locations and going to different parts of the country and trying to source jobs. Many are working below their grade, below their training grade.
And just on the SPRs, can I just ask, is it in
the time will
all
be
categories?
from another Fine Gael speaker subsequently. I'm sorry.
But I'm just looking for
Go ahead.
in what capacity, what areas the SPRs are qualified in?
Across all the specialties, all the training programmes. I can send you later, Deputy Burke, a listing of the number of SPRs who qualified in each of the specialties.
Thanks very much.
Thank you very much, Lee. Thank you.
Sorry to have to cut across you, Deputy Burke, but it's just difficult to get everybody in. Deputy McCall, if you're taking 10 minutes, is that correct? Yeah, go ahead. Yeah.
First of all, I want to thank both organisations for attending today. And maybe at the start, I hope to use some of the responses which you give later on in the sessions with the HSE. Just in terms of engagement, what level of engagement have both organisations had with either the HSE or the department since the pandemic in terms of the restoration or, as you've said yourself, the improvement of service?
Thank you, Deputy. We've been in touch with the Department and the HSE and the National Control Programme since before the first coronavirus case in Ireland about preparing cancer services for the pandemic. And we wanted to ensure that urgent tests and treatment continued throughout the pandemic and that it wasn't the case that everything be prioritised towards COVID at the expense of the non-COVID diseases. So we were pleased that the urgent tests and treatment continued. We continue to have good engagement with the HSE, the department and the NCCP. I think that really to make any progress, we need to see that HSE continuity plan, and we need for that to be funded. And that's where we're going to be able to see what is next for cancer services and what is next for the health service generally.
Ms. Klein?
I have to say, in fairness to the HSE and the department, we engaged with them very quickly at the commencement of the pandemic. More so in terms of the GP side, we have had little engagement or no engagement in terms of building up capacity, and we are disappointed on some of the manpower requests that we have sent in that haven't been addressed. I think, in fairness to both the HSE and the department, the core issue behind most requests from organisations like ours or the Irish Cancer Society is funding.
Okay. Just in terms, I was going to say Ms. Morrow, but I'm very familiar with Ms. Morrow from my previous days in the Rare Disease Task Force, so it seems quite strange addressing her so formally. Rachel, you might outline, in terms of the feedback from the Cancer Support Line, the impact of the mental health of many patients who have already been diagnosed with cancer, and you might outline, maybe, albeit anecdotal, some of the experiences which you've heard.
Thank you. I'm actually going to pass that, though, to my colleague Donal, who's the head of services and has real insight into that.
Thank you. Immediately on the shutdown of the country in mid-March, the Irish Cancer Society extended our nurse line services to a 7-day-a-week service and also longer hours into the evening. The purpose of that was to address the distress which we were hearing on our phone lines on a daily basis. We also were in a position to very quickly stand up a new counselling service to remote counselling service to step into the breach where the usual psychology services just weren't available. And that has been a very successful programme. We have linked in with Cancer Care West and the National Cancer Control Programme to bring in psychology and psychiatry into those services also. And that has been really, really valuable. We've had more than 150 patients have used that service to date. What we're finding now actually is that as lockdown is easing, we are finding that the stress is increasing in cancer patients who are continuing to, many of them who are continuing to cocoon, many of them who remain very concerned about the impact of the infection on them. We have had lots of conversations from parents of children with cancer who are extremely concerned in relation to their child picking up the COVID infection, but also very concerned about the development of their child, about the treatment of their child, and how their family is going to cope with the challenges of continued isolation. So what we're seeing now is that it is becoming an increasing issue. So rather than decreasing and the psychological impact decreasing as we move through the phases of reopening, we are seeing an increased distress and an increased number of people calling our services looking for psychological help and support. And that is something that's going to continue into the future.
And to expand on that point, I know I've been contacted by a number of people who have rare forms of cancer, and while they found the lockdown period very difficult in many ways, as we emerge from that, and there's so much uncertainty about how they can safely operate in society as people return, almost the indeterminate period of how long this will go on is adding, in many ways, in a more severe way in their mental health. Do you believe that the Cancer Society currently is able to meet that demand, or are there additional programmes or funding needed to match on the mental health side of things?
Demand, but that doesn't take the place of a proper funded psycho-oncology service like is envisaged in our National Cancer Strategy. It sets out what I think is a very comprehensive plan for psycho-oncology services, but yet again, it is a funding issue. The funding isn't in place for that. There are also issues for patients in relation to their employment and how, if they are cocooning, if they are at significant risk of infection, how they can engage with their employers in such a way that they can work from home. For many people, it isn't possible to work from home. So there are lots of things that we need to do at this point to support people who remain in that extremely vulnerable position and who cannot, I suppose, enjoy the freedoms that many of the rest of us have enjoyed as we have moved out of lockdown. And I think that needs to be given significant consideration, the mental health, but also joining that up with the services that are required for these people.
The submission outlined the need for a clear communication campaign on the issue of signs and symptoms of cancer, and to encourage people to participate or to attend their healthcare professionals in regard to that. I wonder if you have had any positive feedback from the HSE in regard to that. Our radio waves and television waves are full of advertisements around COVID-19 and so on. Has any of that pre-booked space or ability to deliver messages being considered for to target those people who may be developing symptoms of cancer?
We have run ourselves a communications campaign, and so has the National Cancer Control Programme and the HSE, to encourage people. And we heard the CMO talking about this as well, and Paul Reid, the Chief Executive of the HSE, the importance of getting people into the diagnostics. I think that it's important that we expand those services like the IMO has illustrated, and part of that will be physical capacity. And I suppose just to reassure people that cancers are still being diagnosed throughout COVID, that people are still receiving cancer diagnoses. So if you do have a sign or symptom of cancer, then you really do need to go and seek medical help.
Again, based on what you've been hearing on the cancer support line, for those people who are undergoing treatment, radiotherapy or chemotherapy, and who may have a suppressed immune response, what sort of feedback what sort of issues are you hearing from patients in regard to their experience? Sorry, Donald.
Yeah, so I think what we're hearing is, and we're getting feedback also from our Daffodil Centre nurses, many of whom have worked directly in the acute cancer services over the last number of months, that there are challenges around communication, around logistics, around ensuring that patients can continue to get access to the treatments that they need to get better. And that has been, there has been, I suppose, such an upheaval, transfer of services from public hospitals into private hospitals. Like, we have patients who we bring to chemotherapy treatments through our volunteer driving programme who were getting treated in Tullamore. Very, very quickly, that treatment was delivered in the Hermitage Hospital just outside of Dublin. So there are lots of challenges there for patients in terms of even understanding the new logistics of their treatment without even getting into the detail of the challenge associated with how they're going to navigate the health system.
Okay. Just to move on to the issue of the backlog, which was identified earlier, has the HSE discussed in any way how that backlog may be addressed with either organisations? Do they intend to address it purely through the public system, or are they going to seek short-term capacity from the private system? And I wonder if you have any views on either of those issues.
We've had in relation to the cervical check programme, which is back up and running, and that has always been outsourced mainly to the private system anyway. So the HSE have prioritised women for callback who have, based on clinical need, and with the new HPV element to that test, the length of time before your next callback will be extended, but that is based on clinical evidence, and we're quite happy with that. On the other screening programmes, I don't know how they're going to address the backlog because we haven't engaged on those particular programmes.
And Ms Klein, thank you. The Deputy McAuliffe. The next speaker is Deputy Duncan Smith.
Thank you, and thanks to both sets of witnesses for being here today. If I could just address my first questioning to Ms Klein. You mentioned in your submission being prepared for future surges, and I think we're probably all a bit more nervous about future surges now than we were maybe two weeks ago. But in terms of expansion of acute bed capacity, just two questions. Immediate expansion of physical capacity through investment in temporary builds. Would they be new hospitals built in a temporary fashion, or would it be extension of existing hospitals with temporary builds or anything like what do you envisage there? Because I think people generally get a bit queasy when they hear about something being temporary, and we're thinking of our school system and that. And finally, and secondly, is there any role for the use of private hospitals in providing that bed capacity? I note in the Irish Cancer Society submission, one of the aspects of the health response which they stated supported cancer care was the use of private hospitals for cancer care, saying it worked well and it offered continuity of care for some existing public patients, whilst it may have proved somewhat disruptive to normal schedules. So in your suite of recommendations, is there any role for the use of private hospitals?
Question. I'll ask my colleague Dr Gilligan to answer the first about the temporary bills. On the second point on the use of the private hospitals, if we cannot get into this position where we think the private hospitals will save us. If we add the amount of beds available in the private hospitals and in the public hospitals, we are still below capacity. So the government the previous government decided not to renew the contract with the private hospitals, and the private hospitals, I understand, and the Department of Health are in discussions as to how capacity may be used in the event of a COVID surge. But we are still getting away from the fundamental problem of capacity, and there is a way to move towards this, and people may be a little queasy about the idea of temporary builds, but temporary builds are better than no builds. And I'll ask my colleague Dr Gilligan to expand on this further.
I suppose it's fair to say that the acquisition of the private hospitals for a period of time by the state was absolute recognition of the challenges we've had in capacity, and really what we would like to see in the Irish Medical Organisation, and I can tell you every doctor in the country would like to see, is an actual plan going forward to invest in the capacity requirements of the system. 5,000 beds essentially would look like a 500-bedded hospital. And my concern is that, to my knowledge, there has been no plan as yet put in place with regard to capital expenditure, despite a document, as I say, in 2018 advising us that we needed that significant investment to take place. We need the planners of the country, the engineers and architects of the country to address what the requirements will be to provide that capacity. But we need 5,000 beds. And we also need, with those beds, the specialists in the acute hospital system. We need about 1,600 more specialists in the system just to bring us close to the OECD specialist per capita average. And really, without those, we can't provide the timely care that our patients need in a safe way. Modular builds now are significantly better than they were when I was in school, where the prefabs you could put your pencil through the wall. They're significantly better now, and a lot of countries have invested in these as a temporising measure whilst putting more significant structures in place. There are tents around the country on nearly every hospital campus that I'm aware of, and available capacity within acute hospitals has been looked at, whereby areas that historically weren't clinical areas have become clinical areas in those hospitals. But we really do need to see that commitment. Part of the challenge that we have is that we want to attract specialists back to Ireland, but since October of 2012 we have treated them poorly. We have paid them 30% less than existing colleagues. And as a colleague of mine recently said to me, who took up his appointment after 2012, he said, the applause is very nice, the thanks are very nice, but the reality is I come into work and I get paid 30% less for doing the same job as you, Dr. Gilligan. Is that acceptable? I know it's not acceptable. I know the committee here know it's not acceptable, but we need to address that so we can recruit the doctors we need, the specialists we need in our acute hospital system. Thank you.
Thank you. And just to thank the witnesses, I'm sure the witnesses will accept that if I ask a question on one point on their submission, it's based on the fact that I have 5 minutes here, and I like to hear full answers, and I got a full answer there. But it's not to say that I don't agree or understand the other points that were raised in their submission. So I'd just like to thank. I'm out of time. I'd just like to thank witnesses for their answers. Thank you.
Thanks, Deputy Smith, and apologies again that we have to constrain everybody's time. Deputy Shortall, you're going to be similarly constrained to 5 minutes. Apologies.
Thanks, and it is very difficult to do anything within 5 minutes. But I mean, what we're hearing this morning from the IMO is not new by any means. You were in with us a number of weeks ago. You told us the same thing: lack of bed capacity and lack of staff. Many of us since then have raised that with the Minister for Health, and to be frank, I suppose there hasn't been much indication of a recognition of the scale of the problem. And I mean, it's not only in the last few weeks. Obviously, you've been raising these issues of lack of capacity in the public health service for years, as indeed many of us have been doing. And I suppose what COVID has done is it has exposed the huge weaknesses and inadequacies in our public health service. And, you know, you have to ask, when is government going to get serious about putting in place a public health service that actually meets the need of the population? I just wonder, since you were in previously and members have raised it with the Minister and that, have you had any further contact from the department, either the Minister or the HSE, in relation to the two pressing issues of vacancies, the 500 vacancies within consultants, and the need for rapid build additional temporary capacity until such time as we have the capacity that was promised? Have you had any contact at all at any level to give an indication that you're being heard, that the rest of us are being heard, and that there's any grounds for hope, I suppose, that this is going to be addressed soon?
when there was the change of government, Deputy Shortall, so everybody in the officials of the department and the HSE, they have to wait what the new government will decide they're going to do. But the short answer is no. There does not seem to be any plan for increasing capacity at significant levels. You know, we might get 100 or 200 beds, but that's just not going to cut it any longer, and it's certainly not going to cut it this winter. In terms of the consultant vacancies, you know, when we started this campaign, we started on about 100 consultant vacancies. It went up to 200, 300, and we still have yet to be invited into any talks to deal with this. Okay. What is a crisis in manpower? Okay.
And the 1,000 consultant social care contracts that had been promised a number of months ago, has there been any discussion with you on those?
Discussion with us about, it must be 6 months ago now, and as you know, we do have issues regarding that and the 30% pay cut. Like, I mean, our view is maintained that we are more than happy to go into new contract talks with the government on a public-only contract. However, we are not at all satisfied that this will address the recruitment problem. We do have a public-only contract currently on offer. It's the Type A contract, and we can't recruit anybody on that. And the fundamental problem is the 30% unilateral cut that was applied at a point in time in 2012 that bore no reference to someone's qualifications, no reference to their skills, and was just a political expediency by the Minister at that time. And it has had a devastating effect on the recruitment of consultants to our health services. And people feel it's not actually about the money, it's the psychological impact of you are valued less than the person you're working with doing exactly the same job.
That's a point well made. Thanks, Ms Klein. I'd just like to ask the Irish Cancer Society, what is the position currently about people who are undergoing cancer treatment and who need screening as part of the follow-up to that? Are those people being seen in terms of screening? And my second question relates to the screening programmes, breast check and bowel screening. What exactly is the reason for the delay? It's very hard to understand it because both services are operated separate to the acute hospitals. So do you know why it is that those services haven't resumed?
Thanks, Deputy Shortall. I'm afraid I don't know the answer to your first question. I know that now that cervical check is being resumed, that people who need 3-month and 12-month screens are being included as a priority group, and the people who are entering the service for the first time are being included. With regard to breast check and bowel screen, I think that the screening service is going to be in after and may provide more clarity, but certainly I think one of the issues is the capacity in the hospital system, in the diagnostic. So these are the assessments that people need after they get screened. Because, as Susan said, you know, screening isn't a diagnostic in itself. So, if people are being limited in terms of accessing screening and healthcare because of capacity issues, then that's something that the Irish Cancer Society would be very concerned by. And we need to address the capacity in hospitals to ensure that we're not delaying people's diagnosis of cancer because of capacity issues, and we need to get those screening services resumed as soon as possible.
Ms. Morrow,
sorry, isn't it the case of the screening services, those two are done really outside of the mainstream acute hospital services? So I'm just curious to know, where is the logjam, or where are the obstacles to resuming those programmes?
Yeah, one of the, so say for bowel screen, you get a fit test and you do that test at home, but then if you have a positive fit test, then you're going to need a colonoscopy, an urgent colonoscopy, and that obviously is part of the endoscopy system.
But do you accept that we should at least restart the screening so that people at least know and can be done about it?
Our position would be that if you're limiting people's access to healthcare, so if you're limiting the demand side because there's problems on the supply side, then that isn't acceptable. Then we need to look at the capacity issues, address them, get them resolved, and ensure that people are diagnosed with cancer as early as possible.
Thank you.
Deputy Shortall, thank you, Ms. Morrow. And the next speaker is from the regional group, Deputy Shanahan.
Thank you, Chair. And thanks to our contributors here today. And could I reiterate the sentiments of a previous deputy that they're very, very comprehensive statements. And I think one thing that comes out nearly in them all is frustration. And I'd say severe frustration at that. I think we're all frustrated with what we've been hearing over past weeks, and we also have huge worry about what September, October, November may bring into the health service. Can I just ask in relation to, there was some mention made of the SBRs that weren't given temporary fellowships or asked to be extended in the service. I think it's fair to say that a lot of the waiting lists could be impacted if we were to group them under basically radiology and scopes, and how we might increase the amount of activity there. So is there an opportunity on the Ireland's On Call? I think there was a significant number of retired surgeons had put themselves forward as being available to Ireland On Call, and I understand that technically that SPRs could do some of this radiology and scope work if they were supervised by somebody with greater experience who has kept up their competencies. And are there any plans that you know, or have you spoken to the HSE about implementing something like this after hours, using operating theatre space, using these SBRs and some of the people to increase the activity, the day activity, thereby increasing the capacity and impacting the waiting lists? Thanks.
And absolutely, it's important that we use the resources that are available to us. Having people who've completed their specialist registrar training, they are ready to take up consultant positions. The IMO did ask that they actually be offered temporary consultant positions pending the essentially removal of the lockdown internationally, such that they could travel to undertake further fellowships if they so wish, but they have essentially completed their training. Yes, many retired colleagues did offer their services to the health service again, and it was terrifically courageous of them to do that, particularly given the risk of COVID to older patients, and their help was certainly very, very gratefully received. We do need, however, a more permanent solution to this, and that is about getting the recruitment piece right, very definitely. The challenge is that now, for example, if we want to bring a patient in for a procedure, the patient has to undergo COVID testing 3 days before that procedure, such that we have the result back, so that we know that the procedure can be safely undertaken by the individuals undertaking that, and indeed safely experienced by the person, because we know, for example, that patients with COVID who have surgical procedures do less well from that surgical procedure than they would have if they hadn't had COVID, for obvious reasons. So there are delays in the system as well with respect to obviously the space that patients need, and the processing needs are therefore impacted by that. So it is absolutely a question of manpower and capacity, and definitely I agree with you, using the resources that are available to us.
And could I just ask a question then in respect of the NTPF? I understand that a large amount of the procurement of the NTPF is based on large groups of procedures, probably directed at 1 or 2 hospitals. Is there any opportunity within the NTPF to start looking at smaller bundles directed at more institutions effectively, and I think also using increased service level agreements to ensure that you'll get capacity and continuity into 2021? Thanks.
That, I suppose, first of all, we should be honest and say we don't believe that the NTPF is a long-term solution to the capacity issues in the health service, and in actual fact could deprive the public health services of much-needed funding. We would prefer to see, if there is to be NTPF, and we understand it's going to be supercharged with more money, we'd prefer to see that spending in the public system, for the public system to be supported to deliver more care. Now, currently it is quite complex to be doing business plans and getting funding through. All that needs to be speeded up. You know, medics and clinicians and their nursing and other colleagues on the ground, you know, can be innovative, can, you know, put forward proposals for funding to get that through. So yes, we would agree that NTPF should not just be simply one diagnostic tool based, and in actual fact it might be better spent if the NTPF fund was spent on a whole episode of care to clear the backlog, rather than a whole suite of diagnostics and low complexity, high volume work.
Thank you very much, Deputy Shanahan. The next speaker is Deputy O'Donoghue.
Meeting. Social distance is not happening in the hospitals. Mary Fogarty, nurses representative, says that there is no social distancing happening in the hospitals. On Monday, the 13th of the 7th, 56 patients on trolleys in one area in the regional hospital with a capacity of 20. Capacity of 20 patients. This has increased now to 40 patients. Some patients are sitting on chairs. No social distance and staff are exposed. The INMO have asked for an internal investigation into put controls for nurses to reduce the risk of spreading infection. When you look at the hospitals across the whole country, we see some hospitals are struggling with the pandemic, and we see some hospitals are not. Maybe it's time we started looking at the management system in some of our hospitals that they're not being managed properly. We have our frontline staff deserve to be protected, but also our patients need to be protected. But why have we got in certain situations that we have some hospitals are running well and some are not? So we need to look from a structural point of view how we can help to assist in this. And why is it that certain hospitals are coming under that regime and been stopped? An additional 96 beds were allocated. However, staffing at the hospital has depleted by 20%. Again, is this not something we should be looking from a management point of view? So my question to you is, on a case-by-case basis, and I asked this at our last COVID meeting to do with the meat factories. It's down to certain areas there's management problems, and if you haven't got good management, you haven't got good structure. Every person that goes into the hospital goes in to help, but if there's not a right structure in place, they can't be helped.
And I share your frustrations about the crowding of emergency departments because it has been my experience for many years of my career. Things are challenging around the country, and that's because essentially unscheduled care is just that. Patients arrive when they feel that their problem requires urgent assessment. So for that reason, departments that can't move patients onto the wards for those who require admission are going to become crowded very, very quickly indeed. And that is reflective of the capacity issue. I have to say, in defence of my management colleagues, they have undertaken a Herculean task in the context of COVID. They have reassigned resources. They have helped in the reallocation of spaces for clinical use. They've helped in the reallocation of staff to work in various areas. Yes, of course, there are always areas that can potentially be improved upon, but really our colleagues in management are as clear as I am on this. They don't have the capacity they need to provide the care that they want to provide. 56 patients on trolleys should never happen, and it happens because patients aren't moving through the system quickly enough because there isn't the bed immediately available for them. My
second question is, why is there such a high turnover of nurses in certain hospitals compared to others? That in certain hospitals around the country there's a massive turnover in nurses that are not staying within the hospital system. Is that not just a clear indication with some of the hospitals that there's a breakdown of management or communications to let the nurses do their job properly? They are also frustrated that they can't carry out their duty of care. So we should actually look at, from that point of view, how we can help as well. If there is clusters of areas where there is a high turnover of nurses going through certain hospitals, we should actually look at that to see why is that? Is it because the nurses are frustrated that they can't take out their duty of care?
Again, Deputy O'Donoghue, absolutely. I would acknowledge that there is and remains huge frustration in the system when people feel that the level of care that they would wish to offer they cannot do because of the constraints of the system. The whole system needs to work towards facilitating the doctor, nurse, healthcare professional in delivering the care that they wish to do. We haven't been in that space, but what COVID did show us is that when the system pulls together, it can achieve amazing things with regard to the delivery of safer care. 8,000 healthcare professionals in Ireland contracted COVID in the course of the delivery of the care to patients, which is a very significant number of people who became unwell as a result of the work that they do. We have too many multi-bed wards in the Irish hospital system still. We need to be moving towards more isolation facilities. We have too few critical care beds. We need more of those as well. So as I say, I share your frustration and that of the nursing staff, but we need a system that facilitates us in delivering care.
Time is running out, and we move on to the next speaker. Next is Derry McCarthy.
Thank you. Cahirlock, the submission and the evidence that we've heard from the Irish Cancer Society is probably the most concerning that has come before this committee to date, because essentially the premise of it is that in the efforts to save lives from COVID-19, other lives have been put at risk, particularly those with patients. So just to follow on from Ms Morrow's previous responses, I think you indicated to my colleague, Deputy Cullinan, that if urgent action isn't taken, that lives will be lost avoidably. Just if I look at the waiting times as is outlined in your submission in relation to access colonoscopies, for example, there's an indication that 1,000 people have been waiting for longer than 28 days, 329 people have been waiting longer than 90 days. Would it be a fair assumption to make that lives have already been lost as a result of the restrictive measures put in place with regard to cancer screening services, whether they've been lost or they have been certainly put at risk or will be lost as a result of the measures that have already been put in place?
Thank you, Deputy Carty. To answer your question directly, I don't think that we are at that point. Cancer does take a while to develop, and that's why I was making the point that what we do next will chart the future of the people who we were mentioning earlier, those 450 cancers that haven't been detected yet, or that we would have expected to have detected during a 4-month period of our screening programmes being in place under normal circumstances. What we're worried about is that COVID was layered on top of a system that was not even meeting normal demand. So we've had services, like I said, the non-urgent services were postponed for a quite considerable amount of time because of the need to deal with COVID. And what we're facing now, like I said, is the choice of whether we fully resource and fully fund and look at what it is that we need to do across the health services to meet the backlog and the normal demand. And as you know, the number of cases in Ireland of cancer are increasing annually as well. That we need to take choices that are going to build a sustainable cancer system, because as you and your colleagues have outlined, there will most likely be a second wave. So what we do now
Ms. Morrow, apologies for cutting across you, and I have to say, Cahirlock, the responses required are contained within this submission. I think it's going to be a significant test for the incoming government as to whether or not they put in place the measures that will save the lives of those who go through the trauma of a cancer diagnosis. I'd just like to ask briefly a question of the IMO, if I could. I think they've outlined very effectively some of the deficiencies within our services, but just regarding hospitals and particularly with regard to wards and boarding trolleys and overcrowded waiting rooms. Prior to COVID, I wonder if the IMO had concerns with regard to, for example, fire and health and safety concerns, noting that in November 2019, for example, patients on trolleys were transferred from University Hospital Limerick's emergency department due to an unannounced visit from a senior officer from the Limerick Fire and Rescue Service. Is that a broad concern that you would have, and is it affected by the knowledge of the restrictive measures that will need to be in place during the pandemic?
An issue of major concern to us in the Irish Medical Organisation and for everyone involved in healthcare, that crowded environments would be more difficult to decant from in the event of an emergency like a fire breaking out. But actually the fire has broken out. It's now called COVID, and having crowded situations essentially would allow the spread of this disease. So we can never go back to a situation where Limerick Emergency Department or any other emergency department or hospital has crowded wards or crowded emergency departments. And as we've been saying, and for many years, as many of the deputies have noted, we absolutely now have to have the capacity in place, the bed numbers in place, such that we can safely provide care and indeed, in the event of an emergency, safely remove patients from
one very short follow-on in relation to the response. I come from a county, Monaghan, which has and had very well developed local hospital from which services were removed. And I wonder if the IMO has an opinion or a position with regarding whether or not those hospitals should be utilised in terms of the restoration of some of those services to ease the pressure on other centres.
Final reply.
I think certainly what we need to do is utilise the system we have to its optimal effect. That doesn't mean occupying every bed in the system, because clearly we can't do that. We have to have a facility for surge, so we can't have an occupancy level above 80% in any of our acute hospitals, nor indeed in our elective hospitals. And we need to, the IMO has been of the position that we need to move to having certain hospitals which provide only for scheduled care, such that that scheduled care isn't interrupted by the delivery of unplanned or emergency care. That would be a very important initiative and part of that capacity requirement.
Thank you. Next slot, I think, is probably my own slot. So, very quickly, I would agree, in fact, that we have a capacity issue. It's been there for some considerable time. It's been growing. I believe we have a staffing level issue, and I believe that we have the added complication of people being paid at different levels within the system. That has been as a result of issues which were largely outside the command of most people. So my questions are simply this. Do we now, or do you support the concept of a short-term, medium-term and long-term plan? That's launch a care, effectively. But the implementation of such a plan is vital at this stage, because otherwise, if we have to wait for a long time before we put into operation the things that we need now, then we'll be waiting forever. That's in relation to physical buildings and staffing levels. Who wants to answer?
If I could answer on behalf of the IMO first, Deputy. We have been supporting short, medium and long-term plans for many years now. Unfortunately, the funding hasn't accompanied those plans. And whether you're a supporter of Sláintecare or not, Sláintecare haven't got the funding to accompany those plans. So what we're saying now is, in this current crisis, there are things we can do. We don't need another plan, but we do need to see action on the contingency and building of capacity. We also need to see action in terms of the manpower resource in the hospital. And we also need to say, yes, we have been hearing a lot from the system about shifting care into the community and into general practice. And that is good where it can happen and where it's resourced. So we need a lot of joined up thinking now to get things moving. Staff in particular, working with their colleagues in management and with the HSE and the Department of Health, showed how agile they were, showed the flexibility, how they adapted to new ways of working. That was done in the context of a crisis. That wasn't evaluated as to how it is going to work in the long term and what are the new supports that need to be put in place for that. So I'll just ask my colleague, Dr. McCauley, to talk about this shifting of care to the community and how that could be that could happen over the next number of months.
I think that one of the earlier questions, shifting of some care to the community is a valid concept. Not all care that can be transferred to the actual community, but the care that is transferred has to be planned and it has to be resourced also. I did allude to the chronic disease management earlier on, that I think that will be a very positive development. It has only really started this year. It was hindered slightly by COVID, but we've adapted it. We were innovative in adapting it so that we can look after a group of over 70s in a COVID situation. So I think that it sort of works down. We have to have the actual capacity. We have to have the actual consultants. We can do. General practice is always adaptable. It's always innovative. It always is flexible. But we need to have a plan, and it needs to be resourced. So I think that if care has been transferred just for the sake of it, without it being proven to be useful, I think that's a bad thing. If it's been done just to save money, without any view of the actual benefit or lack of benefit to the patient, that's a bad thing. But if there are certain parts of care which can be transferred, it has been clinically proven to be that we as GPs can at least match that care, and probably, hopefully, as a GP would say at times, even improve that care. If that is feasible and the resources are there, general practice will actually stand up. But if it's incoherent, and if it is not planned and it is not resourced, I think it could have an actual detrimental effect. And this is where I think the system is now in flux, and the last thing we would want is that flux to sort of say that we'll transfer the care to the actual community without all of the personnel being there, the service the people in the actual primary care teams, as well as the GPs there. So I think that it's a very laudable concept, but it has to be effective and it has to be resourced. And I think that there was a talk earlier on about the actual the flu vaccine. The flu vaccine, I think any temperature that occurs in the actual community now will have an emotional and an actual financial effect. If anybody, we don't know if it's COVID until we test them. So the flu is one aspect that I think we can step up. There's now, the previous minister talked about actually vaccinating children. And I think that once again, if that is planned properly, and we would like to get the planning done as quickly as possible so that we can implement it. Once again, it'll be a service which will show that can be effective.
My reason for referring to the short, medium and long-term plan is this. I've been around the health services and associated with the health services for generations now at this stage. And it is only in recent times that we heard the lack of capacity in physical buildings and obviously the follow-on in staff. But it is only still in the last couple of years we were told there were too many beds, when it was obvious to most of us that were on the ground that that was not the case. So I welcome the change in the system, the emphasis and the need for extra capacity, and it is a matter for government, obviously a matter for government, to provide that. The other point that I wanted to raise there very quickly, Mr. Chairman, is in relation to attracting staff and to make the health services an attractive place to work, where job satisfaction is part and should be part of the entire fabric of the system. Can I, if you were to identify the issues now most urgently needed, what would they be in order to restore morale, public confidence in the system and remove the inequalities within the system?
If I could answer on behalf of the IMO, Deputy Durkan, and I think I must make the point that for over a decade now, the IMO has been highlighting the capacity deficits within the system. I think it goes back to many previous governments, probably 2008, when capacity first began to be reduced, and then it was severely impacted and reduced at the time of the financial crisis. And the IMO did warn at that time of the negative impact this would have on future generations. In terms of what we need to attract staff into the system, we need to value them, we need to respect them, and we need to listen to them, and we need to allow them to do their jobs in a well-resourced environment. So from the medic's point of view, from the doctor's point of view, we cannot have two-tier pay systems. That is a disgrace. There is a basic principle, equal work, equal pay. And we are asking doctors who are been headhunted from every part of the globe, we are asking them, come and work here because we value you so much, we will pay you 30% less than the person you're going to be working beside. And then we are surprised that they won't come and work here. We're asking our NCHDs now, who are currently been asked to work 24, 26-hour shifts, and we're saying, come back to this health service, come and work here. We value you, we respect you. We have a GP population where 600 GPs are due to retire over the coming years. And retirement is a huge issue, not just because of the normal issues of retirement, but because of the issues of COVID. And some of these GPs may be near vulnerable ages or have underlying health conditions themselves. And yet we say to our newly established GPs, we have no supports to help you. We are not going to help you set up. You are on your own. So until government address the absolute fundamental basic inequalities in the system, value the staff they wish to recruit, and not just say occasionally in a pandemic, thank you very much. And that is very welcome, and it is good to be recognised. But that has to be the culture that continues. There has to be a culture of respect, paying people properly, and listening to them.
Can I just come in as well? Just in a grouping which is very important in the context of the pandemic are the public health doctors. The public health doctors have basically been working night and day during this period. We've all the healthcare staff have put their shoulder to the wheel, but public health have been particularly in the background working non-stop to try and ameliorate the effect of the COVID emergency. Now, 50% of these public health doctors are due to retire. So we need to attract these public health doctors back into the system. Now, there have been two previous reports. The last one, the Scally report, which has recommended that public health be considered to be given an actual consultant status. Now, we have been advocating yearly for this, but I think particularly during the COVID emergency, when these people have been working night and day, I would say, to the detriment of their own healths, that we should ask that the deputies show respect to these people for two reasons. One is that they deserve an actual consultant specialty status. But if they don't get that, the 50% of the healthcare of the public health people who retire, we will have great difficulty getting these back in, getting these people replaced. Now, the developed nations that had a good public health system did better in a pandemic. Now, they do an awful lot of extra work, but for a safety valve for future pandemics and even the evolution of this pandemic, we have to have an effective public health service. And the fact that they have not been given the consultant status that has been recommended over the last decade, I think is wrong. And I think that to add to all the things that Ms. Klein add, I think in the context of the public health emergency, public health doctors should be respected with that contract, so that we can ensure that the service remains even static, but actually develops. Thank you.
Dr. McCauley, and thank you, Deputy, and thank you also for stepping into the chair. The next speaker is from Fianna Fáil. You're coming back in.
Thanks, Chair. And just to come back to the point, I think it was Dr. McCauley or Dr. Gilligan who mentioned the issue of the flu vaccination. Obviously, in the fight against COVID, a comprehensive and more widespread flu vaccination programme will be needed. And I wonder if the IMO particularly, but also in terms of cancer patients, both organisations might comment on what they would like that vaccination programme to look like and the issues which they may see arise.
I understand the HSE will make some proposals to the committee this afternoon in relation to the flu vaccination, but it has already been announced that the flu vaccination will now be extended to children between the age of 2 and 12. The IMO had called a number of months ago for government to look at a total population vaccination programme and to sit down and talk to us about that. What we're concerned about is that we are now coming towards the end of July. We need to sit down and talk about the flu vaccination programme now. Respiratory illnesses will start circulating early September, and we need to have a plan. We need to understand what is going to happen so that GPs can prepare. We have to acknowledge the fact that the days of a full waiting room in general practice are long gone. There are no more walk-in clinics. Everything is by appointment. So GPs will have to actually prepare to a certain extent for some vaccination clinics and we need to sit down with the HSE. Now, we are due to meet them next week, but we would have been in favour of a total population vaccination programme delivered in general practice.
And from the Cancer Society?
As you probably know, cancer patients are considered an at-risk group, and so they are encouraged to get the flu vaccine every year. And certainly the Irish Cancer Society will be doing our part in that regard and encouraging cancer patients to get vaccinated. I think that it's really important as well that while we'd expect cancer patients probably there to be quite a high uptake, that we encourage people at a population level to go and get vaccinated this year. And when we think about the impact of flu and seasonal diseases on actually the treatment of cancer care, and we know that elective surgeries are decreased by about 15% during the winter months because of the impact of flu on the hospital system, that we really need to, with the reduced capacity that we're now experiencing as a result of COVID, we really need to do everything that we can to ensure that people aren't going to end up hospitalised and to keep capacity for the urgent cases.
Thanks.
Sorry, Deputy, if I could just make one further point. We have to have a strong campaign to give people confidence in vaccinations. We can see from surveys, you know, the anti-vax movement is quite strong. It's operating strongly on social media, a lot of it around the potential of a COVID vaccine. So the system needs to be sending out a very coherent message about the vaccination programmes and the safety of the vaccination programmes.
I think that point needs to be underscored later on with the HSE as well, that vaccination saves lives. We've seen social media used positively, but during this pandemic, we've also seen it used very negatively in terms of misinformation. And I would add to your comments on the vaccinations. Could I just ask the Cancer Society, in terms of the other services which you provide, fundraising is a huge component, particularly in regard to research. Have you put a figure on how much you'll be down this year as a result of not being able to avail of fundraising activities, or have you found alternative methods?
Thank you, Deputy. So the Irish Cancer Society operates largely on fundraising from the general public and from support from corporate supports also. About 98% of the 24 million income from the Irish Cancer Society last year was fundraised. We expect to see a significant deficit this year. We have, like I think everyone knows, our flagship Daffodil Day event, which takes place at the end of March every year. So unfortunately, it wasn't possible to run that event this year on the streets as we normally do. It raises about €4 million every year, but we were able to pivot and transition that fundraising effort into online, and we're able to raise €2 million, so half of what we would have expected to raise. We are working very hard to ensure that we can continue to raise the funds that are needed to support the frontline services that we provide, and we have always had the support of the Irish public, and they have been putting their hands in their pocket and supporting us as we have changed our fundraising methods over the last 6 months. We will run a significant deficit, as I said, in 2020. We expect also to run a deficit in 2021 and 2022. We have reserves in place to address that. We have reserves in place to ensure that the frontline services that we have can continue, that we can enhance those, and we can continue to address the needs of cancer patients over the next number of years. In terms of research, the research has been significantly impacted by COVID-19. All clinical trials for cancer in Ireland stopped in February, and no new trials have opened since. That has a significant impact on the potential outcome for many cancer patients, but also has a significant impact on the psychological well-being of patients, again, not being given access to novel clinical trials, not being given access to potentially life-saving new treatments. There are also issues in relation to our infrastructure, our research infrastructure, where many of our researchers are on precarious contracts. They haven't been able to do their work over the last 5 or 6 months, or only been able to do a proportion of that work over that period. Will they be able to extend those research grants? Will they have the funds to be able to continue the research programmes that they had hoped to deliver? The Irish Cancer Society is committed to research and will continue to invest in research, particularly in research which is closer to the patient, which allows us to really understand the quality of life issues and the patient impact issues that people who are diagnosed with cancer in Ireland will face, not just now, but into the future. 65 people today will be told that they have cancer, and 25 people will die from cancer today. If we don't invest in research, those numbers are going to increase. If we don't invest in research in Ireland, we won't be able to access the world-class cancer doctors that we need to deliver a world-class cancer system.
And when you say, Donald, that when you say there will be a significant deficit, are you prepared to put a figure on that?
I might have to come back to you on that, Deputy. I'll have to come back to the committee on that. I would rather give an accurate figure on that rather than I have a figure in my head. I'm not sure. The
last question: I had the great pleasure of launching the volunteer driver service for the Irish Cancer Society last year with. In Beaumont Hospital, and I just wonder what the impact of the pandemic has been on recruiting volunteers for that driver service across the country.
One of the first steps that we took on the shutdown of the country was to ensure that services like our volunteer driving service could be maintained. We have drivers who are over the age of 70 and who are in the extremely medically vulnerable category. So of the 1,000 volunteers that the Society had going into the pandemic, about half of those were temporarily stood down to protect them from the COVID-19 virus. We were able to develop new online training programs and recruitment programs for new volunteer drivers, and thankfully were able to take on board more than 100 new volunteers, which allowed us to maintain the level of that service at about 98% of all requests we met over the pandemic period. We were also able to connect in with services like Lifeline Ambulances, like the Order of Malta, and like the community committees and the county committees which were set up to ensure that any cancer patients who were looking to access their chemotherapy services were able to do so. And I think we are totally indebted to a cohort of magnificent volunteers who, when no one was travelling anywhere in the country, were bringing cancer patients to and from their appointments.
The committee would urge the Irish people to support you in meeting both the financial deficit and the deficit of volunteers to try and continue to support cancer patients. And I want to say to both organisations, thank you for being with us today.
Thank you, Deputy McAuliffe, and thank you, Mr. Bogey. Deputy Function.
Thanks, Chair. Thanks very much to our speakers. I want to ask the Cancer Society specifically about the cervical screening. And I think I'm one of the last speakers now, so apologies if this has been raised already, but I'm wondering, would you have any information or figures for exactly, particularly for the Carlow Kilkenny region, how many women are waiting on a retest, not the initial test, but a retest where there was symptoms, and given now all of the delays and everything with COVID, would you know how long that backlog would be specifically for that region? And if you don't have that specific information, maybe in general you could comment on the issue of the cervical screening and the delays, please.
Thank you, Deputy. I'm afraid we don't have that data, but I encourage you. I think the screening service is in this afternoon, and they may have that data. And if they don't, we can certainly ask them through our own channels if you don't receive it. With regard to the resumption of screening, like I said earlier, and I'm sorry if you missed it, but we do welcome the resumption of cervical check, but we're disappointed that bowel screen and breast check have not resumed. We don't have sight of specific data with regard to backlogs that for the official figures. So the screening service may be able to talk to you this afternoon about specifically what it is. We've done our own calculations with regard to the number of cancers and precancers that have gone undetected, or we think that have gone undetected during the period that screening has been paused. And with regard to cervical cancer, we think that in the last 4 months there would have been about 1,000 precancers that wouldn't have been detected, and about 33 cervical cancers. So that's obviously of major concern to us, and just underscores the need for the screening services to resume as fully as they can as soon as it's safe to do so.
Thanks. And my second question is also linked, or is also for the Cancer Society. I know obviously this was a very serious situation and everybody has to take all of the advice and the public health measures seriously, but do you believe that there was the need to cut the services to the level that they did? Was there not some safe way of being able to carry out some of these cancer screenings, in your opinion, I suppose, given, I mean, obviously COVID is extremely serious, but there are so many illnesses, and cancer being one of them, that affects so many people, and obviously early diagnosis is key in everything. And I'm just wondering if there was not a way for us to be able to carry out some of those screenings. I'd just like to know what your opinions are on that.
The advice that was taken by the screening service and by the health services generally was by NEFIT, and I think that was the evidence base on which screening was paused. So I'm afraid I can't answer as to whether that was the right decision or not, but that was NEFIT's advice.
The only reason I asked that is a lot of women in particular would have contacted myself, and I'm sure they contacted other people too, just with the frustration of seeing certain shops and retail outlets being allowed to open, and yet they know that they needed maybe a secondary test and they're being told that was too risky. You know, I suppose just the irony of that, particularly if you're worried and you're in that situation. You know, I just think myself that maybe some of the screenings and at some point could have maybe been resumed a little bit earlier than they currently have. And as you've just said, a lot of them haven't even been resumed.
Deputy, perhaps I can address that insofar as we didn't know in March what the pandemic was going to bring to us in terms of COVID-19 and in terms of the capacity in the hospitals. So we supported the decision to pause the screening services at that time. Similar decisions were taken right across the European Union. Many countries shut down their screening services. But what many have done is resume their services quicker than we have in Ireland. So I think what we need, or what we are lacking, is that ambition to get those screening services up and running and to link them into the capacity in the hospitals that is required to manage patients who, having gone through the screening programme, need further diagnostics and treatment.
Thanks, Chair. That's it.
Thank you. Ms. Klein, you said that you called for a total vaccination programme. When did you call for that total vaccination programme, and what response has there been to date? Sorry, I don't mean to limit the possibility to response to Ms. Klein. I mean all of.
Yeah, it's in our submission actually to the committee, and we have indicated this before. Now, we're not saying that we're looking for a mandatory vaccination programme. We're saying that the HSE should fund a total population vaccine programme. So at the moment, the HSE fund the vaccine only for at-risk groups and for those in the at-risk groups, even on the GMS. So they fund the actual physical vaccine, but not the administration of the vaccine. And we have called then, in light of the need to limit respiratory illnesses and flu in the community, we have called for the vaccine to be available on a total population basis, but it is to be available voluntarily. We would encourage the total population, but we don't want to get into the debate of whether it should be mandatory that you get the vaccine or not.
Okay. And have you received a response, or has the IMO received any response on that yet from?
No, we are to talk to the HSE. Have indicated they want to talk to us next week about the winter vaccination programme, but we do note in that they have already, and there has already been an indication announcement that they're looking at expanding the at-risk group to 2 to 12-year-olds, but we would not believe that that would be sufficient.
Okay, so you think basically it should be free to everybody in the population.
Yes, we think it should be free to everyone in the population, not just the vaccine, but like a properly delivered vaccine programme within general practice should be free to everybody in the population, so that we can improve the uptake, maintain records, and have a real understanding of where we are with a total population cover.
You've mentioned, both in response to, I think, Deputy McAuliffe and to me, that it would be within general practice. Is the vaccine currently administered by pharmacists at the moment?
Vaccine can be administered by pharmacists, but our view is that it's better in general practice. Your health record is more complete. It's more holistic approach. Very often when people come in for a vaccine, there's an opportunistic consultation where other issues are addressed. And I think, particularly in the current circumstances, it's safer within general practice.
But would you accept that it is safe to have it administered by pharmacists? I mean, do you think there's a particular danger at the moment posed by pharmacists administering the vaccine?
No, and I don't think we ever said there was a danger caused by pharmacists.
Question. So you don't think it's dangerous for pharmacists to administer it?
No, I don't think it's in the best interest of the patient. I think it's better to have their healthcare needs met within general practice.
But, I mean, which would be the priority, that there be a total vaccination programme, or that the vaccination programme be administered in general practice?
Look, that there be a total vaccination programme. Pharmacists do administer vaccination programmes. We are not saying that they shouldn't, but we are calling for a total vaccination programme for the population, which is not a mandatory vaccination programme. But
and I thank you for clarifying that. But what level of, I mean, I'm not a medic, but I do know that certain levels of vaccination are particularly beneficial. You know, once you achieve a certain level, there's a certain level required. For example, with is there not with mumps and stuff like that? Sorry, I say stuff like that. I've recently had a child who was vaccinated, but and I don't mean stuff like that. But I do know that certain levels are beneficial. Do you know what the level is before there's a particular benefit?
Varies with the age group. In relation to the flu vaccine, it has been found that if you have a coverage, if you have a lower coverage in children, the rate of spread of flu is actually less. So they would think that at a level of about 65%. In the older age group is what is necessary to sort of prevent it from spreading quickly. But the English research would say that if this is the first year that we're planning to do it with children, and it'll be a different mode of administration. It'll be a nasal. My understanding, it'll be a nasal drop. But if you get a smaller proportion of children, the evidence in England is that the spread is less. So it sort of varies which population you look at. When the Sea of Snot starts in September, they feel that the children are not particularly sick with the flu, but they do spread it quite a lot. And that's unclear with regards to COVID, and this is another issue as well. But in relation to flu, so in answer to the summary, it varies. The amount of, if you can administer less children, you get greater results. It's just, but that's the English data. We haven't any comparative data in Ireland.
I missed what you said. When something starts in September, what?
Just the kids going to school, and they're mixing and social distancing, and there's a thing called the winter plan. The winter plan has started. The creches are open. The amount of childhood infections are actually beginning to come in. We had no childhood infections at all, essentially, since March. But now with the creches coming in, we're seeing children with temperatures. It's just that social distancing is, even within the pod system, there will be a certain amount of mixing. So it's the children with regards to the flu are thought to be significant vectors. They're not that symptomatic, but they do seem to spread it.
Seeing children presenting with COVID, or are you seeing children presenting with influenza?
It's a completely separate issue. At the present minute, we're awaiting adjudication from NEFID in relation to children, whether children need to be tested when they present with a childhood illness with a temperature of 38 and a cough, and that's something that we'll have to wait for the adjudication of NEFID. I know that there's different data. There's data from Israel that show that they could cause infections, that they could spread infections. There's evidence from Finland and Denmark that opening schools didn't cause an increase in infections. So there's two diametric facts. Then the European guideline, the European infection control, I think they're going to publish at the end of August something in relation to this. So at the present, I can't answer that question.
But just to go...
Sorry, just generally, Deputy, on the subject of vaccinations, like while it might be about 65% for the flu in that age cohort, it is, as Dr McCauley says, very different across the population. So the HPV vaccine for girls and boys in schools, we'd be looking for everybody to participate in that. And for the childhood vaccination programme, like you'd need herd immunity of over 85%. So we're always pushing for the maximum number of people to be vaccinated to give that herd immunity.
And for flu, I mean, do we know what is the percentage required to achieve vaccination? What percentage of the population would require to be vaccinated from the flu to achieve herd immunity?
If you were going on the present system, it's above 65–70% to be effective. Now that's going on the Irish situation in the flu vaccine is available to at-risk groups and people over a certain age. So going on the Irish dynamic, that's what is necessary. But as you say, when you extend it to the whole population, that effective figure could change. That's the point I'm saying.
Yeah, no, thank you. But
what Ms. Klein said, the higher the better. Because I think, as I said earlier on, just any temperature that occurs in the actual community now will cause an awful lot of psychological worry and will cause economic effects, because we don't, with regards if a child has a temperature or an adult has a temperature, they will have to, the actual quarantine, the time they have to stay at home will have economic effects as well as health effects and psychological effects. So the less temperatures we have, the better.
Thanks. When does the flu season typically start?
It varies really. The flu, it came early last year. Generally, from any time from September to January, it just varies. I think the flu vaccine has come in. It came on time in Australia at the present minute, so we'll imagine that it'll come late October. But last year it came early.
So, if we're to achieve herd immunity from flu, or if we're going to get the percentage of the population required to be vaccinated, again, everybody's stressing that it will be a voluntary vaccination. I mean, nobody will be forced to, but time is ticking.
I think we've been advocating that we engage with the government about this for the last 2 months. I think since the Minister Harris announced that the vaccine would be extended from 2 to 12, we have been interested to liaise with the department about this, and I think our first engagement will be next Wednesday.
Did Minister Harris, after he made the announcement, was there a follow-up consultation with those who would be administering the vaccine or might be administering the vaccine?
Preliminary discussions with the HSE on this, and like I said, we have to meet them further next week in the context of the rollout of the programme. It is important to note that, we will always encourage everyone to get the flu vaccine. And for employers to make it available to their staff and to get the vaccine. And while it should be, it needs to be got, it doesn't have to, it's not that if you don't get it by the end of October, it's not beneficial. You keep on going while the flu is circulating.
My question specifically was, after Minister Harris announced that he was going to increase the programme, was there a consultation with those who were going to be implementing it carried out?
No, not a detailed consultation. No, we are expecting that to happen now.
Waiting, okay. Thanks. Then I suppose, obviously, COVID-19 is a serious virus with very serious consequences in terms of mortality, but even those who survive it, many suffer very debilitating lifelong conditions. Equally, the response to COVID-19, which has resulted in various people not presenting for routine medical procedures and screening programs being in abeyance, is going to result in excess mortality. I mean, which, if I could ask a very simplistic question, or perhaps it's overly simplistic, which is going to result in a greater mortality? Do you think COVID-19 or the response to COVID-19?
The excess mortality at the moment is not that high, and that is only going to be something that we can evaluate as the evidence comes in. I am concerned that we are looking at our health services as if this crisis is because of COVID-19. We had a crisis. COVID-19 has made it worse, and that's why we have to take such significant and huge steps at the moment in terms of investment, and no more, planning. There are a myriad of plans on health. We just want some investment based on clinical evidence and patient need. So I think I don't think we could answer that question on mortality, but we would be, unfortunately, of the view that mortality will increase at a higher level than it would otherwise have done. But mortality is increasing within our health services because of the capacity issue anyway.
My last question is, how does the Irish return to screening in cancer screenings, how does that compare to international? And maybe it's a question that the IMO may be able to answer, but also in particular the Irish Cancer Society. How does Ireland compare to other Western European states with regard to screenings currently being carried out and plans for return to screening programs? And if it's unfavourable, do you know why? What is the causing any differential?
Thanks, Deputy. So we've tried to find this information. We've been using our European networks to try and get good information, but it's a bit patchy. We know that in the Netherlands that screening has resumed there on a priority basis, though. So they have colon, breast, and cervical cancer screening. And the first case of COVID was diagnosed in the Netherlands on the 27th of February. So the invitees are being prioritised on the basis that first clients who received their initial invitation before March 16th but had their appointment cancelled have been re-invited, followed by the clients that should have been invited after this date. And in Portugal, again, the information isn't totally clear, but in the central and southern regions of Portugal, breast screening has been or has resumed since mid-June, and bowel and cervical have returned, but we don't know what date that happened. So, in terms of Ireland, like we've said previously, we really do want breast and bowel screening to return as soon as possible. And if the reason that cancer screening hasn't returned is because of capacity issues, then it underscores the point that I think both organisations have been making today, that there needs to be real, substantial, sustainable investment in capacity so that we're able to ensure that people get access to healthcare and cancer services as soon as they need them, and that will ensure that we limit the number of excess deaths and that we give people a really good opportunity to live a healthy and a good quality of life.
Thank you very much, Ms. Morrow. Deputy Durkin, were you looking to come back in, or?
No, I'm fine.
Okay, thanks very much.
I'm in your hands, Chairman.
Well, we can wrap. I mean, if there's a question you wish to ask, you can ask it. Otherwise, we can.
Well, I have already raised the question in relation to capacity and the priorities and the manner in which we should set about achieving the necessary capacities. And I would just simply say this: that I think the IMO said that they had been pushing this issue for the last 10 years. I have to say, Chairman, that I've been at health meetings in the last 5 years and 4 years, when the suggestion that we had an overcapacity in beds came up again and again. I didn't believe that at the time. But I want to put another issue before our witnesses, and that is this. As our population expands, and it is expanding, and if we recover, and hopefully we will recover fully from the pandemic as well, economically as well as in terms of health, then the demand will get bigger again. And the question obviously then arises, are we well placed to provide the level of services required to that higher population? And I'm not referring to the ageing population, which everybody refers to, because there's also an influx of young people who are employed in this country, and that has been the pattern for many years, and that will continue to be the pattern. So there are children's issues as well, family issues, as well as older people's issues. So I just would like to know that issue is in hand, and those at the coalface, the front line, are prepared to push for the necessary facilities there.
Yeah, I think you can be assured that all healthcare workers at the front line are not only prepared to push, have been pushing for a long time for the facilities. The short answer is no, we are not